We have a new thing in Switzerland. It's a mandatory spine implant registry. And I want to share our first experiences with the first 3 years. It was introduced in 2021. And we'll talk a little bit about the structure of this registry. Then I'll show you the reports, the EPROMs which are incorporated, and then early changes which we did due to certain issues. So this is the structure. It consists of a foundation board with specialized medical societies from neurosurgery and orthopedics, and also the implant manufacturers, the insurances, and the hospitals are involved. Then there's the board, the SSAB, the advisory board, where I'm a member, as you can see, but also Amin and others from neurosurgery and orthopedics from spine. Then we have the administrative office, and then there's an interchange with EUROSPINE, NEC, obviously for the data handling, and ANQ. So the initial inclusion criteria for this registry you can see on the left. So it was 1 or 2 level spinal fusion with implants for degenerative entities or spondylolisthesis, and operated only via a posterior approach and the revisions of them. And on the other hand, we included vertebroplasty and kyphoplasty, but only fresh fractures, less than 29 days in the thoracic and lumbar area, and the revisions of them. So it was the initial setup of the registry, and I show you the data from that, and then I explain to you why maybe you can assume why it was changed a little bit later. So already in these 3 years we have more than 12,000 cases from 92 hospitals in Switzerland, more than 80,000 implants from 65 manufacturers. So there's a vast variety of manufacturers, as we know. These are the hospitals, and you can see all the 92 hospitals and the case numbers they added to the registries. Most have less than 50 cases included, but there are also some high volume centers which you can see on the left side. Then following the inclusion criteria, obviously this is mostly degenerative disorders and osteoporotic fractures, being 60% and 12%, and some spondylolisthesis. Then the age group, the mean age is 67, but the main group is above 70 years old, and then there are some really old, about 80. The gender distribution is female 58%, and the ASA classification is most have mild systemic diseases, being 53%. Then the mean body BMI was 26, a little bit overweight, but the main group was normal weight, as you can see here, between 20 and 25. The majority, or at least let's say half of the cases, had no prior surgeries, and the other half had prior surgeries, with 30% having just 1 prior surgery. So a high rate of patients, or number of patients, having had prior surgeries. They were all, but this also following the inclusion criteria, posterior approaches, mostly midline, as you can see, over 70%, but also the Wiltshire approach and some others. Then also following the inclusion criteria, that mostly the techniques of fusion was TLIF, and 46% and 35% were posterior or posterolateral fusions. Then here's some early results. You can see the revision rates over time, and depending on the age. So as you would expect, the higher the age, the more the patient would have revision in these 3 years. So with being over 80, it's almost 10% and being under 45%. But these are only patients included in the registry right from the beginning. We can discuss that later. Then there's no difference between men and women. And if you look at the comorbidities, the ASA classification is also what you would expect. The more sick the patient is, the higher is the risk for revision. Then BMI, also as expected, a higher BMI is correlating with a higher rate of revisions in this time period. Interestingly, the underweights have the lowest revision rate. Then this is a funnel plot. There you plot the expected rate of complications against the actual rate. And this is corrected for certain factors, BMI, age, and so on. And by that you can compare actually the hospitals, and you can see with the red dots being 3 hospitals having more revisions than expected, and with the blue dots less revisions. The same is true for dural lesions. So you can monitor the rate of dural lesions. You can see here all these 92 hospitals from Switzerland. They're anonymous, and you can see one center, which is a high volume center, which has a higher rate of dural lesions. And keep in mind they are corrected already for other factors like revisions, BMI, comorbidities and stuff. Then the e-prompts, patients get emails or text messages, and then they can fill in this e-prompts. This is the COMI, it's well known, EQ5D, and a so-called Swiss orthopedics minimal data set, which is similar to the COMI. They have it pre-operatively and 12-month post-op, and they get 14 or 19 questions. And I think you are familiar with these, with prompts. Then, as you remember, what I said in the beginning, the initial inclusion criteria were just posterior surgery, just 1 and 2 level and revisions, and this caused a little bit of confusion and hard to understand. And also it was very hard for us to validate if, like, all hospitals were really documenting all cases. So we decided to change that, and now we include all lumbar spine surgeries involving implants, which are newly implanted, which are in situ already, or explanted. And that makes it much easier, and also regardless of the approach, is anterior, lateral, or posterior approach. And we can, with the Swiss CHOP codes, with the surgery codes, we can validate those. So taken together, we have, in these 3 years, more than 12,000 cases registered in 92 hospitals, a lot of implants from many manufacturers. We can document a lot of variables, as you can see, and we can assess quality in terms of e-prompts from the patient perspective, but also revision rates and complications. We can theoretically monitor implant or implant problems, and we have changed due to our learning process in the meantime, and with the childhood diseases, we have changed our inclusion criteria. Thank you.